Welcome to The Explainer. Look, if you or someone you love has navigated the world of IVF, you already know the stakes are incredibly high. And honestly, the science can feel totally overwhelming. Today, we're unpacking a deeply complex and often heartbreaking topic: why IVF cycles fail. We're going to break down the exact variables at play objectively and empathetically, so you can really understand the medical mechanics behind implantation and empower yourself with that knowledge. It usually boils down to this one incredibly frustrating question: why do visually perfect embryos sometimes fail to implant? You see this beautiful, highly graded embryo on the clinic monitor, but the cycle still doesn't work. To figure out why, we need to take a micro to macro diagnostic journey, looking at everything from the microscopic cells to the broader systems of the human body. So, let's quickly look at our roadmap for today. We'll be covering 1. The embryo equation, 2. The uterine environment, 3. Hormones and systemic factors, 4. Technique and lifestyle, and 5. Unexplained and next steps. Seeing it laid out like this really helps make an overwhelming topic a lot more systematic and understandable.
All right, Section 1, the embryo equation, starting at the cellular level.
We have to start our timeline at the very beginning with the single most common culprit of a failed cycle: the embryo itself. And specifically, a crucial term you need to know: aneuploidy. This refers to chromosomal abnormalities within an embryo. Aneuploidy explains the paradox of why an embryo that looks completely normal, or quote-unquote perfect to the embryologist's eye, might sadly fail to implant or cause an early miscarriage. The genetic blueprint inside the cells just isn't viable. Now, what's driving this? Well, the overarching variable here is maternal age, which heavily dictates that aneuploidy risk. It's really the dominant factor influencing almost every mechanism we're discussing today, primarily by driving up the risk of those chromosomal errors as time goes on. To put that into perspective, just look at the raw math. While around 30 to 40% of eggs are affected by these errors in a woman's early 30s, that number spikes to over 75% by her mid-40s. It's a stark statistic for sure, but it really helps demystify why implantation rates change so dramatically over just a single decade. But hey, it isn't strictly about genetics. We also have to look at cellular quality. On the egg side, declining quality brings oxidative stress and mitochondrial dysfunction. And we can't forget the male factor. Sperm issues like low concentration, poor motility, and especially high DNA fragmentation severely compromise viability. Ultimately, these factors can cause the embryo to experience developmental arrest, meaning it just stops growing entirely before it even reaches the blastocyst stage.
Moving right along to Section 2, the uterine environment, preparing the soil for the seed.
Zooming out from the embryo itself, let's look at its immediate environment, the uterus. This is honestly staggering, but endometrial receptivity issues actually account for up to 2/3, a massive 66% of all implantation failures. Think about that for a second. The seed might be genetically flawless, but if the soil isn't ready to receive it, the embryo simply cannot take root. So what's actually throwing up these roadblocks? Well, a thin lining is a big one. Ideally, it needs to be at least 7 to 8 millimeters thick. You can also have altered adhesion molecule expression, but perhaps most critically, there can be a timing mismatch with the window of implantation. This is exactly why specialized tests like the ERA are sometimes recommended. They make absolutely sure the embryo isn't being transferred outside of that perfect, fleeting window of time.
This environment can be further complicated by structural abnormalities. We're talking about polyps, submucosal fibroids, intrauterine adhesions, also known as Asherman syndrome, as well as things like a septate or T-shaped uterus, adenomyosis, and hydrosalpinx. Any of these can mechanically or functionally block a pregnancy. And I really want to highlight chronic endometriitis here. It's this quiet, low-grade, and very often underdiagnosed inflammatory infection that can silently disrupt implantation without giving you any obvious symptoms. Which brings us to Section 3, hormones and systemic factors, the body's signaling network. Let's see how the body's broader hormonal signaling builds on this foundation. Implantation relies on some truly exquisite chemical timing, and hormonal imbalances completely disrupt that delicate dance. Low progesterone, estrogen dysregulation, elevated prolactin, and insulin resistance-linked PCOS can all impair early pregnancy. Even super subtle issues, like subclinical hypothyroidism or a suboptimal stimulation protocol causing a premature progesterone rise, well, they can completely desynchronize the endometrium from the embryo's development. And then, of course, there's the immune system. Immunological factors, things like elevated natural killer cell activity, a T1/T2 cytokine imbalance, or other thrombophilic and autoimmune conditions are frequently brought up in cases of recurrent failure. But it is really important to point out that while they are heavily implicated by some, this remains a much more contested area in medical evidence. The scientific community is still actively debating their direct impact.
Okay, Section 4, Technique and Lifestyle, the external variables. We absolutely have to consider the outside variables, which encompasses both the medical procedure itself and day-to-day life. On the clinical side, a traumatic embryo transfer, catheter resistance, or incorrect placement can directly reduce your odds of success. But please don't overlook lifestyle factors: smoking, excess alcohol, obesity, poor sleep, and high stress. These aren't just general health buzzwords, right? They are distinct variables that consistently lower success rates by quietly degrading both egg and sperm quality, as well as impacting how receptive the endometrium is.
Finally, Section 5, Unexplained and Next Steps. Navigating recurrent failure. This brings us to what might be the toughest pill to swallow in this whole explainer. What happens when absolutely everything looks perfectly right, but the cycle still fails? Astonishingly, clinicians estimate that at least half of all failures involving a chromosomally normal, good-quality embryo combined with a normal-appearing endometrium remain completely unexplained. 50%. It just really goes to show how much of human reproduction still happens at the very edge of our scientific understanding. And that leads us to a specific clinical diagnosis: recurrent implantation failure. This is formally defined as experiencing 3 or more failed cycles with good quality embryos. If you hit this clinical threshold, your medical team is likely going to pivot from standard protocols to a much more rigorous and investigative approach. So, what does that formal workup actually look like? Well, here is your actionable checklist. A workup usually includes a hysteroscopy for a direct look at the uterine cavity, alongside ERA testing to verify that implantation window timing. It also involves sperm DNA fragmentation testing to make sure male factor issues aren't hiding in plain sight. And finally, thrombophilia and immunology screening if your specific clinical history indicates it. You can literally take this list directly to your doctor to start uncovering those hidden variables. Armed with this breakdown of the seed, the soil, and the systemic factors, I want to leave you with this final thought for your next consultation. Which piece of the implantation puzzle should you investigate next? Knowing the structured categories of why cycles fail really empowers you to ask the right questions and advocate for your own care. Thank you so much for diving into this with me. Stay focused and keep learning.